Hello, my fellow pathologists. A very good morning. This is Dr. Ranjith, your pathology educator at Unacademy. So today we are going to discuss one more pathology nuggets for postgraduates. These are case discussions which might be helpful for postgraduates who are going to give exams, but just to see a variety of cases. And these are all from our archives where we are going to see a case from a low power, high power, the differential diagnosis, what thought process went in as a pathologist when I'm going to look at the history, when I'm going to look at the slides, right? We'll look at everything in the series. We have close to 15 plus videos in the YouTube channel of Unacademy. Under my profile, you can go and have a look whenever you're free. And we have also had a very good amount of case discussions and theoretical plus analysis of cases in the Unacademy app. You can download the app with a link given in the video description. You can use PathoCups to unlock all these classes. All these classes are free and they are for postgraduates. And you can join the Telegram group when I'll compile the link of all of them and give it to you so that you can watch them in your leisure time, right? And these will be interactive and live. If you are available live, it will be the best thing. You can ask whatever doubts you have, we can answer the questions, we can discuss together, and both of us will grow together, fine? And you can download the lectures of it. The images, whatever is being shown in the class, will be in the form of a PDF which you can save it for you for later discussion. And you can watch on a laptop, mobile, or tablet, whatever you wish to, fine? Okay, hope this series will help postgraduates to learn and understand better about pathology and will hone our diagnostic skills, yours as mine, fine? So without any delay, we'll go to today's case discussion. This is also a bone and soft tissue lesion. I'm going to have the same history, a 12-year-old history with a lesion in tibia. Like I told in the previous pathology nuggets, whenever it's a bone lesion, please do not diagnose in a hurry. Always it should be in consultation with an MSK radiologist. An MSK specific radiologist should give an opinion on that. Again, I am not saying that general radiology is not good, but MSK radiology is definitely much better than bone lesions, fine? Because there's a very, very big role played by radiology in the differential diagnosis, sometimes in the first diagnosis as well, right? And when it's a 12-year-old kid, like what we saw in the last case, we saw a case of a fibrocortical defect or a non-ossifying fibroma in the last pathology nuggets, right? Just to quickly review that case. If you missed it, please go to that and have a look. A non-ossifying fibroma in a microscopy had no bone tissue. It might have a little bit of bone tissue. What it had was a solid area of spindle cells, a very bland looking thin spindle cells, scattered giant cells, and hemocyte and macrophages, right? That's what we saw in the last case. So this case, I'm having the same differential diagnosis of 12-year-old lesion of tibia. It could be a fibrocortical defect, it could be a fibrous dysplasia, it could be an aneurysmal bone cyst, it could be an osteosarcoma, it could be anything. It could be Ewings as well, right? Anything is possible because I didn't give you the history of your epiphyseal or metaphyseal or diaphyseal. So it can be anything under the sky, right? So with a very broad and open mind, we're going to look at the image, and I have like 4-5 images, and I will describe everything. Whenever you're watching this video, if you're a postgraduate, please start describing along with me, fine? So when you look at this image here, what you're seeing in this image primarily is, I'm sure that first thing which is strikingly there for me is pleomorphism. I'm sure you will accept that as well. Look at this, it's definitely not normal, right? It's huge somewhere, it's small somewhere, definitely hypochromatic, increased cellularity, right? And if you look at this image especially, what I'm predominantly seeing in this image is the cartilaginous part, right? You can see the chondroid matrix, the blue colored tinge in the background. Plus, yeah, these are actually lacunae. These are actually lacunae in which you have the cells inside them, right? Like here, have a look in the 12 o'clock portion. I have a beautiful lacunae inside which I have a cell. So now I have a lacunae inside which is a cell. I'm going to think of a chondroid lesion. But one thing which is in the back of the head is the history. A 12-year-old, and it looks malignant for sure. A malignant chondroid lesion at 12-year-old is a bit unlikely. I'm not saying it's not possible. I always had my professor say that tumors don't read textbooks and we read textbooks, right? So keep that in the last differential diagnosis. It could be a malignant chondroid lesion. I'll come to it soon, right? If you look at it, yes, I do have multinucleation. There is definitely pleomorphism and it's destructive as well, obviously, right? So that's the first finding. I'm predominantly seeing a chondroid lesion, right? I'll go to the next image. Again, whatever we had discussed in the previous images become much more confirmatory here, right? Here again, cartilage, a huge lacunae with definitely an abnormal cell. This is definitely an hypochromatic cell with a high NC ratio. Again, pleomorphism is present, obviously it's present. I'm having a cartilaginous differentiation, right? In this image, yeah, mostly a cartilaginous differentiation. We'll go to another image. We'll see if we find anything else. Same thing. Maybe this part doesn't look like a cartilage, but to be frank, it doesn't look like an osteoid as well. It's neoplastic cells, that's what I can comment there. I can see there is predominantly cartilaginous differentiation in the lower half. When it goes to the upper half, it kind of has a slight different color. See, colors are the most important thing. It has a pinkish hue in the area which is marked with an arrow mark. Whatever is in the below is definitely having the cartilaginous look. Yes, definitely pleomorphic in the top. I do have lots of cells with pleomorphism, and if you look at this, my video is hiding a little bit, but still you can look at the mitotic figure, right? And irregular and abnormal atypical mitotic figure. So again, one thing which is confirmed here is I'm not dealing with a reactive condition. I'm definitely dealing with a malignant condition, because ATPR in bone can be seen in reactive condition as well. So what made me say it is definitely malignant in this biopsy especially is the mitotic figure, not the normal mitotic figure, the atypical mitotic figure. That is like, I can write it out as malignancy. When you see a single atypical mitotic figure, I'm going to lean towards malignancy. Pleomorphism is not the thing, because I said that there are lots of conditions where you can have pleomorphism in your reactive bone tissue. So don't keep it as the first. Necrosis might be seen sometime, but when I see necrosis, generally I'll lean towards malignancy only. Fine. Go to the next image. This image is much more characteristic for me, right? Definitely I have chondrodilation, but if you see here, what are these? I'm sure you'll accept that whatever we saw, a hint of whatever we saw in the last image, it's much more prominent here. I do have osteoid, and these are definitely osteoid, right? I do have a pink color, the streaming osteoid going into the cartilaginous area. Maybe this is the site of the differentiation, right? So if you look at the osteoid here, it's simple. When you see osteoid, the first thing, when you see any bony fragments, I want you to think of two things only: whether it's neoplastic or non-neoplastic. The way to call it neoplastic or a malignant osteoid is they should not have an osteoblast rimming. I don't have an osteoblast rimming here. I'll erase this if you want. See here, it's a pure osteoid. It's just a trabecular entity inside. It doesn't have a rimmed osteoblast, right? These cells which look like an osteoblast, they are actually the chondroid differentiation cells. They are not the osteoblast. So they are a pure osteoid without an osteoblastic rimming. That's my first thing. So I can easily say it's a malignant osteoid, right? So there's no confusion here. It's definitely a malignant osteoid. The second thing, what I want you to differentiate, keep in mind when you have any bone tissue or osteoid is, see whether it's a lamellar bone or an oven bone. Lamellar bone will have the lamellations, which means it's a normal bone. Oven bone is anything which is abnormal, because oven bone will happen when there's any wound injury, be it fracture in a callus tissue or any type of injury has to the bone. When the bone regenerates, I'll have an oven bone formation, which will not have the lamellations, which is going to be haphazard. It'll be very haphazard. That's how an oven bone looks, right? So these are two things I want to think of. Anything when you are going to think of your bone tissue, fine. So here, I don't want you to get misguided saying that this is an abrupt differentiation, because when you see something as an abrupt differentiation, we call it an de-differentiated tumor, right? Especially in sarcomas, there are lots of de-differentiation. Almost in every soft tissue, de-differentiated liposarcoma, chondrosarcoma, osteosarcoma, and there are many of them, right? This is not an abrupt transition. I have searched for this image and I put it there, that's all. So it looks like it's transferring from chondroid to osteoid, but any tumor with a differentiation to another lineage will have this kind only. To call it a de-differentiated osteosarcoma or a chondrosarcoma, I should have an abrupt differentiation. We will see in the upcoming pathology nuggets what do I mean by abrupt differentiation and when can you call it your de-differentiated tumor, right? This is not abrupt, it's just merging inside. It's just merging inside. You can see here as well. Just going here. In between, these are also osteoid, right? These are also osteoid matrix. In between, I have the cartilaginous areas, the cartilaginous cells as well, right? Okay. I do have a couple of more images. Look at this image. Definitely malignant. I do have osteoid permeating inside as well, right? And if I can notice, I'm going to highlight this, something in the 12 o'clock. Maybe I'll use an yellow marker. Something in the 12 o'clock question, definitely an atypical mitotic figure, right bang in the center, here, great. This I want you to get used to. See, mitotic figure is something, if you're an oncopathologist, you should be very, very comfortable with picking in, even in an 20x. If you're not comfortable in 20x, please go with 40x and pick it up. To identify mitotic figure, especially atypical mitotic figure, it is easy only, but at some times, whenever you have a very cellular tumor, Not here. See, here is not a problem. Here is the cellularity is sparse. So you won't make a mistake most of the time here. These images are very classical of an atypical mitotic figure. When you have cellular lesion, especially in a leiomyosarcoma, a soft tissue tumor, spindle shaped tumor with high cellularity, what happens is the nucleus tends to come very close together. So I won't have this much space. So there what's going to happen is I'm just going to draw it here. We'll take this area to draw it and explain what's going to happen and what will be my problem. I'm having a tumor like this. I'm having a tumor cell here. I'm having one more tumor cell here. In between the tumor cell, I have only this many tiny areas for the nucleus, right? The area of nucleus itself is very, very small. There, if you have a mitotic figure like this will qualify for a ring mitosis. It's an atypical mitosis, right? Now, a ring mitotic figure, one thing which can easily confound your diagnosis is lymphocyte. That also looks small, round, and blue color, right? That also looks that you have to differentiate from them. The dictum to call something as mitotic figure, first and the foremost rule is the nuclear membrane should be absent. Look at these three mitotic figures here. Is there a nuclear membrane? No. No nuclear membrane, no nuclear membrane. It should be absent. If the nuclear membrane is present, it is not a mitotic figure. That's my first rule. That should fit into, and please be very careful. Search. And one thing is, when you search for a mitotic figure, when you count for mitotic figure, this is one common mistake which most of us do. What we do is, we count mitotic figures. It said that it should be always counted in contiguity. What do we mean by that? Is let's say that this, I'm just taking a paper for explanation. Let's assume this is an entire field for me. So in this entire field, if I have to previously itself come to a conclusion that, okay, I'm going to count the mitotic figure, especially in this area of the field, in the left corner area. That's where I'm going to do it. So if you're going to do it here, go to a higher power, count 10 fields continuously. Don't take 2 fields here and go to low power. Choose one more area with high mitotic area and 2 fields there. Go to low power, 2 fields here. That is wrong. Which means you're going to search in areas of high mitosis, which might falsely increase your mitotic figures and it might upgrade the lesion. Almost every standard WHO says is, choose the area where you're going to count mitotic figure in a low power, 10x maybe, and go to the area in a higher power and count it continuously 10 fields. You have to count continuously. You should not search for all the fields where you have high mitosis. That might make it abnormal because it's distribution. You should always count like that. So you see, it's a single field here. So if you have to start with this area, I'll go to the left, right, 10 areas, 10 high power fields. Generally 10 high power fields is more than enough, except for few rare cases like GIST, we will require more high power fields, fine? Okay. So this is how you go to mitotic figure, and we know how to pick up mitosis as well, fine? Next, last image. You can see kind of this tissue is undergoing necrosis. You can see the carrier debris a little bit. It's kind of getting lost, right? So I do have areas of necrosis as well. So there is no problem for me to call this an malignant. You saw the malignant osteoid, you saw the chondroid areas as well, and it's a 12-year-old kid. And I know straightforward, you won't have more easy diagnosis than this. It's a classical case of a chondroblastic osteosarcoma. It's a chondroblastic differentiated osteosarcoma only. The differential diagnosis here, there's not much of a differential diagnosis. As I said that, if the age is not given, my chondrosarcoma might become a problem, right? Because in the initial few images, I saw lots of your cartilaginous malignant cells. So I might think of a chondrosarcoma. Keep that in mind. Chondrosarcoma, generally, it's going to be in elderly people. Mostly likely 40-50 plus years age group. In that age group, osteosarcoma can also come, which is secondary osteosarcoma. That time, I might find a difficulty. In this case, not much. Second, chondrosarcoma most often, again I'm not saying always, most often occurs in your flat bones. In the sternum, ribs, flat bones. Long bones of tibia and fibula, chondrosarcoma is a very unlikely lesion, right? So keep it down the road. When I have a tibial lesion in a young age group, this is unlikely possibility, right? Okay. So for chondrosarcoma, how do I pick up case of chondrosarcomas? I think I had put one more pathology nuggets regarding chondrosarcoma. We had discussed the grade 1, grade 2, grade 3, how to differentiate all of them, atypical chondromatous tumor, when to call it and everything. So if you have time, just go and have a look. If not, we'll discuss definitely in the pathology lectures which happens in the Unacademy, fine? Okay. So one more differential diagnosis. This is not exactly a differential diagnosis, but I want you to remember this, right? I want you to remember this here. Look at this. Can I say This osteoid here has lots of pleomorphic cells. That's definitely an osteoid. I'm sure you won't make a mistake of not calling it an osteoid. It definitely has pleomorphic cells, right? So this pleomorphic cells, I should not call it, jump and call it a neoplastic osteoid, and I should not call it a malignant. As you can see here, it's marked here, it's in callus tissue. Callus is a regenerating tissue. So anywhere you take a biopsy from a callus tissue, it will show lots of signs of regeneration, which is pleomorphism. Things which will tell me or helps me to rule out a malignancy here is, first thing, look at the osteoid. Am I right in saying that they do have osteoblasts? Though if not continuous, they do have a significant amount of osteoblasts. You can look at an osteoid here. They're definitely surrounded by osteoblasts, right? That's my first clue for me. You have a perfect osteoblastic rimming. When it's that, it is not malignancy. Second, and the most important thing, though I can have very pleomorphic cell, extremely big giant cells, you might not see your mitotic figures, right? So everything should align here. Necrosis might be seen in callus because it's an wound healing. Any wound healing in body will have cell death, so that should not confirm my diagnosis. That should not make me over-diagnose and malignancy, right? So when you have a callus tissue, first history is there. The MSK radiologist will give me an input. Just with pleomorphism, don't call it a malignancy. Your pointers for malignancy in and bone tumor is pleomorphism, atypical mitotic figure, and neoplastic osteoid formation. Necrosis and pleomorphism might be there in regenerative conditions as well, right? So callus is one thing, but you don't want you to miss it. And like I said, osteosarcoma is definitely a differential diagnosis in an elderly or in secondary osteosarcoma with a chondrosarcoma as a differential diagnosis. Right? Last one, just to complete it, we do have Ewings sarcoma and a small cell osteosarcoma. This might end up as a problem because Ewings can also happen in the same age group. Ewings can also happen in the same site. Both small cell and Ewings can have the same appearance, small round blue cells, right? It's a very, very challenging thing. First and the foremost thing, the hint should come from the radiologist. And obviously, radiologist can easily pick up Ewings. Hint should come from a radiologist. There are few subtle clues for saying it is Ewings and not a small cell osteosarcoma. And we'll, maybe it's beyond the scope of today's discussion. I'll lengthen it much more. We'll discuss in one more case how to differentiate Ewings versus small cell osteosarcoma based on morphology. Here I'm just going to add only one finding based on IHC, because Ewings, or as per the recent WHO 2020 says, it's not Ewings, it's an undifferentiated small round cell tumor, right? Any Ewings or an undifferentiated small round cell tumor has to be picked up on an IHC only. I do have IHC for osteosarcoma as well. There are lots of IHC for osteosarcoma. One which has been commonly used, we'll see it now, right? Ewings, I'm sure you must have read about multiple markers for Ewings, starting from the first and the initial person who's been there for a very, very long time, but not much useful in real life, CD99. I do use it when everything else comes negative, right? It's like a fallback marker because CD99 will be positive in many small round cell tumor, including lymphomas. So I would say that, at least for diagnostic protocol, not the first one I'm going to think of, right? So what is the marker can be Ewings positive? After your CD99, there's a marker which calls Fly1. I'm sure some of you must have seen them as well. Fly1 came into existence, and Fly1 came into regarded as one of the best markers because it's in sync with the translocation. Because in Ewings, we have Ewing sarcoma gene getting translocated with Fly1. That's one of the commonest translocation. The other translocation was with ERG, right? So Fly1 was still considered better. Again, it's not the best as on date, right? As on 2021, as we are speaking, we have lots of better markers here, right? To call it Ewings or to call it an undifferentiated small round cell tumor, I want you to rely on NKX2.2. See, NKX2.2 is a very, very, very useful marker. Okay, it's a very useful marker. It's positive in almost every case of Ewing sarcoma. There are few places where this can be negative in the undifferentiated small round cell group. Again, Ewings has lots of differentiation. We have something called as BCOR mutated, CCOP mutated. We'll look at Ewings and undifferentiated tumor sometimes down the road, fine. So NKX is one marker which I'm going to rely on. This is definitely positive in case of Ewing sarcoma. And coming to small cell osteosarcoma, this is positive for any osteosarcoma for that matter. But when I see in classical osteoid, I might not require this. If you want, do a SATB1. SATB1 is a very, very good marker. SATB helps you to differentiate in small cell osteosarcoma from a Ewing sarcoma. There are a few other markers called as MDM2. MDM2, if you have, that also will be positive in case of an osteosarcoma, might not be positive in case of an Ewing sarcoma, fine. So this ends today's discussion. So what we saw was a 12-year-old kid today, and we had gone through the entire panel of spectrum of differential diagnosis, fine. Thank you for your time and thank you for watching. Please download the Unacademy app and do come and join us in the pathology live classes. And I'm excited to learn more with you guys, and your input is making me better, and it's going to be vice versa, and it'll be mutual, fine. Thank you for your time. Bye bye. See you soon. Till then, bye bye from Dr. Ranjith.